Good morning, ladies and gentlemen. It's a great pleasure to welcome you once again on this, the 12th edition of the ISG Masterclass. This morning, you are seeing a slight change in the format. Instead of Professor Govind Makharia starting the session and introducing you to the session, I am doing the honors for the simple reason that Professor Makharia is the speaker this morning. So far, we have had 11 excellent sessions of the ISG Masterclass that have been thoroughly enjoyed and appreciated by the audience. As you know, we have had a large number of people tuning in for this program, not only from India, but from neighboring countries, several African and Middle Eastern countries. And the response has been quite gratifying for the ISG Governing Council. Today, the topic on which Professor Makharia will speak is an approach to a patient with chronic constipation, which is an extremely common problem, seen quite as much by the general physician, if not more, than by the specialist gastroenterologist. So I expect Professor Makharia to speak to the physician as well as to the gastroenterologist in how they would approach this problem. For this morning session, the panelist is none other than one of our very recent past presidents and a well-known figure in gastroenterology circles, Dr. Naresh Bhatt, who is tuning in from Bangalore and will be moderating during as the session moves along. You're all familiar with the format. In fact, so familiar that we can already see about half a dozen questions in the chat box awaiting Govind even before he has begun his talk. So all of you are requested to send in your queries on the chat box, and somewhere halfway through his talk, at about 20-25 minutes or so, Professor Makharia will break, and we will have a few questions that will be taken. The session will be conducted by Professor Naresh Bhatt, and thereafter we'll complete the talk. At the end, as we've been doing in the last 3 or 4 sessions, Dr. Makharia will have a few multiple choice questions for audience participation and audience poll on these questions. And then we'll take up as many of your questions as we can manage before we wind up for the day. With these few words, I will now invite Dr. Govind Makharia to please deliver his talk on an approach to chronic constipation. Govind, please.
Thank you so very much, Dr. Saraswat. I'm so happy to join ISG Masterclass today as a speaker, and this is a true honor to me to speak to very august audience. Thank you, Dr. Bhatt, for moderating this session, and I'd like to share my screen, and we go to 1 second.
Yogita, can you help out with the screen sharing? Seems to be again a problem.
Sir, can you see yourself, Dr. Govind, sir?
Just 1 second.
Might be it's got minimized.
Oh, yes. Half the screen, Govind.
Yes.
I think you need to set that right. Yes. We have it now.
The screen visible?
Yes, I think we have the full screen now. You're all set.
Thank you so very much again. And let's talking about how do you approach a patient with constipation. Again, I've posed a 6-step strategy for looking at patient with constipation. What it is, how do you classify constipation, know the patient factors which can modify the presentation of constipation, map the disease, treat and optimize, and we'll talk about certain special situations where constipation can be difficult to treat. Coming first to what it is. So if you look at the constipation and the normal physiology of defecation, we have a stool comes in the rectum, and this stool keep accumulating in the rectum. There's increase in intrarectal pressure, and subsequently there will be many more things will happen in the anorectal coordination, which leads to stool. But there has to be enough stool in the rectum before the defecation reflex starts. If there is a defecation reflex to start, there has to be increased intrarectal pressure, and defecation occurs, then there will be relaxation of pivorectalis muscle that leads to opening of angle between rectum and anal canal, and also there's a relaxation of external anal sphincter and internal sphincter, and everything is complete, then there will be passage of stool completely, and the person will have a complete defecation. So this is normal physiology. If there is any defect out here in the process, they will lead to constipation. For example, the coordination at anorectum is of extreme importance. So here what we have, if there is a stool in the rectum, and if the whole process does not happen completely, there's no incomplete relaxation, or the sphincter does not relax completely, the stool will pass, but only some amount will pass, and patient will have a feeling of obstructed defecation. The whole stool, despite a full defecation, the stool will stay in the rectum, and therefore it's important that this person, the stool will remain for a long time in rectum. Therefore, the stool may become hard and dry, and the person will have to strain to pass this stool out. There will be persistent urge to pass stool because the rectum has stool persistently, and patient might have to use the finger to remove this stool. So this can happen if there is an anorectum incoordination, and these are the four important manifestations of anorectal disorders. It can also happen that we know that the whole colon has to move to stool to come to the rectum, and if there is an inertia in the colon, if it's inertia, and there's a lot of stool will get accumulated, but it can't be propelled to the rectum because of colonic inertia, and therefore rectum will remain empty. If rectum will remain empty, there won't be urge to pass stool, and therefore they can have no urge to pass stool. So what is constipation? The classical definition of constipation, which we know for a long time, is passing less than 3 bowel movements per week, less than 3 stools per week, which are spontaneous. This is called classical definition. But every person has a different perception. A person, in terms that if you ask people who will come to you with a complaint of constipation, that they would complain that I pass hard stool. My stool is not of good volume. I don't pass. I feel that my volume is not good. I don't have bowel movement every day. I don't have bowel movement in the morning, or they could be feeling of incomplete evacuation. And many people will complain constipation for any abdominal wellness. They have lack of terms. They have lack of vocabulary. Therefore, they'll say that anything in the abdomen, they will say constipation. So this is what we call is a self-diagnosed constipation. So many people in our society will have these symptoms, and they would diagnose themselves that they have constipation, and this is how they come to us. So if you look at how many people will have this kind of perception that they have a constipation, and this is data from West that about 14 to 45% people in the population perceive that they have constipation. And the same data is there from our country, from a study by Dr. Ghoshal, which is a multi-center study, and where almost 50% people said that they're not patients, they are healthy people, but they said they had constipation. And then another study from Chandigarh which say that 24% has self-perceived constipation. But if you apply definition of constipation, which is by Rome 3 or Rome 4, then you find that only 11% or 3% have constipation. There's a huge gap. People perceive that they have constipation, but if you apply criteria for constipation, only 10% have constipation. And furthermore, that 1/3 of people who don't complain, but you apply criteria for constipation, you will find that they have constipation. So they don't complain. They are not health seekers in our society. So question comes, how do I distinguish that this is a perceived constipation or this is true constipation? And this is a basic question we need to understand once we approach a patient with constipation. So for that, we have 2 points to discuss. The first one is a symptom complex. What is the kind of symptom the person has? The other one is the stool characteristics. What is stool characteristics? Again, the Rome definition for constipation, that the person must have at least 2 or more of the following 6. 2 or more of following 6, and this will be there at least 1/3 time of all defecation. And what are these? Less than 3 bowel movements per week. This will be straining, lumpy or hard stool, sensation of incomplete evacuation, sensation of blockage of stool, the stool can't pass, and manual evacuation. So any 2 of these in 30% of time of defecation, they qualify for constipation. Furthermore, this would be onset to be at least for 3 months, so it will be a chronic symptom rather than an acute symptom. Now coming to other characteristics, so we have a 6 symptom lasting for at least 2 of them for lasting in at least 1/3 of defecation, and other one is stool characteristics. And there are the 2 points. All of us know the rectum is the driver of frequency. The defecation reflex starts from rectum. If rectum is irritable, for example, what happens in IBD or in IBS, they will have diarrhea. If rectum is not moving, rectum has no sensation, therefore, if rectum has no sensation, therefore, there won't be onset of defecatory reflex. So rectum will keep dilating, and that can lead to constipation. And second, longer the stool stay in the colon or rectum, the water will be absorbed from the stool, and they become hard and dry. And hard and dry stool is difficult to pass. And how do we know that? We know by looking at stool characteristics. And I think there's need of change in practice out here. And we believe, and everybody believes, those who are the world experts in constipation, that using Bristol chart is extremely important and give a hell amount of information while making an approach to a patient with constipation. So type 4 is a normal type of stool. If the stool stays longer, it will become dry. Dry stool will break. They become sausage, and there's a lot of breakage, and it can become pellet-like. They break and form small pellets. So type 1, type 2, which are separate heart lumps or sausage separate, this is a constipation. Many people will say that I pass stool like this, but still they'll complain constipation. And so therefore, the patient may have different perception, but if you use this chart, it will tell us that there is a defect in the somewhere in the GI tract, which leads to persistence of stool in the colon or rectum for a long time. So please use Bristol stool chart, and they can be easily used. When they are all available on internet, you can take a print and keep in outpatient. And maintaining stool diary sometimes does help that what kind of stool person is passing, and this really helps in optimizing therapy. If you give therapy, patient still have this kind of stool. In that case, you will advise or add on more therapy. So those who have perceived constipation means those who don't meet the criteria of Rome 3, stool is not that kind of, as we described, the Bristol stool, they don't need any investigation. They just require our reassurance. We need to educate them. And this is the point of I want to make out here. This is the point which will help. At least we know 50% have a perception, 10% have true constipation. It means 40% have perceived constipation, and all those 40% is a large number, can be treated just by reassuring them. Ask them to increase the fruits and vegetables, and also utilize a gastrocolic reflex. We know the gastrocolic reflex is important, that once a person eats, there is a colonic contraction that's called gastrocolic reflex. So ask the person to go to toilet or washroom and try defecation for at least 5 minutes twice a day after major meals, 30 minutes after eating, and even there's no urge. So these patients will be requested to go to washroom after their major meals within half an hour, even there's no urge. And probably they will learn from this, and the constipation may get better. So the first point, that most of the patients have a perceived constipation, only a small number have true constipation, and the treatment is counseling, education, and utilization of gastrocolonic reflex. Moving to second part, that is how do we classify constipation? We know constipation is caused by a disease in the small intestine, large intestine, or anorectum. The disease of small intestine does not lead to constipation unless there is a stricture in the small intestine. But constipation means mainly large intestine and anorectum. So constipation can easily occur if there is obstruction to the flow or in the tube. There is an obstruction by either by tumor or inflammation. There will be constipation, and they are typical organic disease. If the colon wall does not move, and if there is no propulsion because of myopathy or neuropathy, so the stool will not move from one part of colon to other part of colon, and therefore this can occur also both because of organic diseases like myopathies or neuropathies, or by functional nature also. If there is a defective anorectum we just discussed, there could be pelvic floor dyssynergia, and in many people there is a constipation. There is true constipation, but no demonstrable etiology, and they are typical functional constipation. So organic, all we know that any kind of obstructive lesion, mitotic lesion, solitary rectal ulcer, proctitis, fecolis, all can lead to constipation. And second group is once there is any amount of myopathy or neuropathy, either primary or secondary. Secondary means those who have diabetes, those are hypothyroidism, those are hypercalcemia. There is a myopathy, and therefore that can lead to propulsion in the defective propulsion in the colon, and therefore constipation. One must remember that these disorders have a huge spectrum. To start with, when the colon does not move, they will not have classical symptom of no urge to pass stool, but they will behave like irritable bowel syndrome or functional constipation. But as time passes by, months and years, they lead to chronic intestinal suture obstruction. So all these patients have chronic intestinal suture obstruction. They'll come to us with constipation as the prime symptom, say a couple of years before. So as I said, if there is a defective propulsion, so the stool will not come to the rectum will remain empty, and therefore they won't be asked to pass stool. And same pathophysiology, this is what we call slow transit constipation. It means the transit is slow in the colon, therefore there is a constipation. And this is a very important disorder we need to understand. And this can lead to chronic intestinal suture obstruction. The second point is a defective anorectum. Again, this is very important to understand that how it happens. So for this, we have a stool in the rectum, but again there's a defective propulsion, and the stool does not pass completely. It gets obstructed because of incomplete relaxation of external anal sphincter, which is a condition called anismus. If there is incomplete relaxation of anorectal sphincter, this is called anismus or pelvic floor dyssynergia, and therefore there will be obstructed defecation. Again, we know symptoms, the stool will be hard, dry, there will be straining, there will be persistent urge, and there will be manual evacuation. This condition is also called earlier as fecal evacuation disorder or obstructed defecation. So what a type of constipation? We discussed functional or organic. Majority of constipation are functional, 80% are functional, only 20% are organic. And among the functional, we have three types: normal transit, which is typical functional constipation, or we can IBS constipation type. We have slow transit, where colon does not move, and we have pelvic floor dyssynergia. And more importantly, there's always a combination of any of these, and they can come as a combination. In organic, we know we have mechanical, we have drugs, and we have systemic causes. So for second part, majority of constipation are functional, 20% organic, and this could be normal transit, slow transit, and pelvic floor dyssynergia. Moving to the third aspect, which is also extremely important, no patient factors. And what are these factors? Setting is important, age, higher age, low food intake because of any cause. Somebody has a advanced mitosis, they will have low food intake, therefore there will be constipation. Then there is not enough stool to induce constipation or induce defecation reflex. There could be multiple underlying conditions. Medical conditions can also induce. There could be multiple drugs, immobility, depression, and all of these either they are the primary cause of constipation or they can modify the severity. Suppose somebody had IBS, and if they start taking drug for depression, the symptom of constipation will increase in severity. So this could be either sole cause or there could be modifier for constipation. Coming to what are the disorders which systemic diseases which can lead to constipation. We all know multiple endocrinopathies, some like diabetes, hypothyroidism, hypercalcemia, or even chronic renal failure can lead to constipation. Anybody who has a central nervous system disease or peripheral nervous system disease can also induce constipation, either as a modifier or as a primary cause. And we all of us know about it. Multiple drugs, especially those if you prescribe iron, opiates, anti-Parkinson's drug, or anticonvulsants, all of these can induce or increase severity of constipation. Immobility, fractures, bedridden, cognitive impairment, spinal cord diseases, all will be either modifier or could be a sole cause of constipation. I want to make one more point out here that if there is a small polyp or tumor in the colon, they will be totally asymptomatic. But as time passes by and the tumor increases in size, the symptom will keep appearing slowly, and there could be a time when there will be complete constipation, obstruction, and therefore constipation. So one must remember that a new onset constipation or worsening of pre-existing constipation, especially in elderly, must be given due importance and they must be investigated. So for the third step, we need to keep in mind the setting of the patient's age, comorbid illness, and how rapid the constipation severity has increased. Rapid increase in severity simply means this is an organic disease and this person surely requires investigation. Now moving to the fourth step, that is to map the disease. And how do we map the disease? Answer 5 clinical questions, and all are to be done at bedside or in our outpatient clinic. They don't require, this mapping disease does not require any investigation. First, is it functional or organic? We know 80% are functional, 20 are organic. So the first question comes that is it functional or organic? And some of the pointer, they're not telltale signs, but there's some of the pointer that this is a functional constipation. That if there's a long-standing symptom, if there's no weight loss, no fever, if there's no bleeding, there's no mass palpable, if there's no history of obstruction, intestinal obstruction, and if somebody had a associated bladder dysfunction and also age of onset. So if we have these same setting, then it's most likely to be functional. But again, remember that organic disease, if person has, will not be long-standing. So those symptoms, we must, which points towards organic, that new onset symptoms, weight loss, anorexia, bleeding manifestations, fever, and family history of chronic malignancy are the pointer toward organic disease. So this point should help us deciding in our clinic that this is a functional or organic as a predominant type. And if it is functional, then look at if it is irritable bowel syndrome. If it's irritable bowel syndrome, which is now either use Rome 3 or Rome 4 criteria, and where constipation is associated with abdominal pain. And all these should get, if there's a constipation, should get relieved by defecation. So if you use Rome 3 criteria, you will show, or Rome 4 criteria, you will know this is a IBS. Now coming to important point that if somebody has a constipation, prolonged straining, excessive straining, distal evacuation, feeling of obstruction in the pelvis or heaviness in the perineum. So if there are any of these, they point towards pelvic floor inertia. And this is again important that we must ask this question. The patient will not know and will not tell us these points, but we as a clinician to understand the pathophysiology, we need to ask these questions. And these questions are the pointer to tell us if the person has a pelvic floor dysplasia. So now we know organic disease, we have pointers. But in functional disease, we talked about three conditions: normal transit constipation, slow transit constipation, and pelvic floor dyssynergia. Question: how do I distinguish these three? And this is a very important clinical question which all of us has in our clinical practice. And to do that, I would take your attention to two important things: one symptom, one sign. And this will differentiate between three of these conditions: one symptom and one sign. What is symptom? And symptom is simple. I made a point earlier that urge to pass stool is one of the very important clinical symptoms which classifies constipation. Suppose if there is a slow transit constipation, if there's a myopathy or neuropathy, colon is not moving, there's a chronic inertia, the colon is therefore rectum will remain empty. If this rectum empty, where is the urge? If urge starts from, or defecation starts from, rectum sensitivity. If there's a rectal hyposensitivity, there won't be urge. Like for example, megacolon. So slow transit constipation patient will say, I pass stool every 7 days, I don't have urge. And those people who have a stool has to go to washroom every 4th or 5th day or 6th day or even longer, they are not IBS for sure. They are slow transit constipation, and these patients require investigation. Suppose somebody has a whole rectum is full of stool, but there's a defect in evacuation coordination. That's called anorectal incoordination defect, either because of incomplete relaxation of external anal sphincter or internal anal sphincter. If there is a lack of relaxation of puborectus muscle, if the muscles are weak, especially elderly people, then this angle will not change, and therefore rectum will remain full, they will have incomplete evacuation, and they will have persistent urge. Every time they feel there's an urge to pass stool. Urge to pass stool which is persistent tells us that there is a pelvic floor dyssynergia. And normal transit will have a normal urge to pass stool. So please remember, urge to pass stool is a very important sign, and at least we can make these two diagnoses on clinical ground. And one sign which all forget to do as a gastroenterologist or a physician, to do a digital rectal examination. And this again point is important because if there is an anorectal defect, if there is a not relaxation of anal sphincter, external or internal, how do I know that? Suppose we put a finger in the patient's rectum and by doing a PR, and what happens at this index finger, on the distal phalanx, you will feel the pressure of sphincter, and ask the person to defecate over your finger. So once he defecates, if it's normal, the sphincter will relax, and therefore you will find that there's a less pressure on your index finger. But paradoxically, it can constrict because of external sphincter. Rather than relaxing during defecation, during attempted defecation, there will be increased pressure on your index finger. You know for sure this is a defect in relaxation of external anal sphincter. Therefore, this is a pelvic floor disorder. So doing a per rectal examination is an important, especially to distinguish if the person has a pelvic floor dyssynergia. And it is seen that by doing a distal rectal, you can diagnose 73% compared to manometry. Therefore, some people call this is a golden finger. DRE is now called golden finger in terms of constipation. So, one more point, with this clinical, we come to who needs investigation. And we know 80% functional, 20% organic. So those people who have signs of organic disease like weight loss, anorexia, low hemoglobin, bleeding per rectum, fever, and if they have a mixed with diarrhea, all these patients will require investigation because they point towards an organic disease. And if they have features of pelvic floor dyssynergia, or if there are features of slow transit constipation, means no urge to pass stool or urge to pass stool, they would require investigation. I think I'll stop here. So for this fourth step, map the disease, classify if there is a slow transit, pelvic floor, IBS, or organic. 2. Urge to pass stool and distal rectal examination, and filter out patients who require investigations. I think I'll stop here, and we can take some questions. Dr. Saraswat and Dr. Bhatt.
Well, Govind, thank you for a very crisp
Yeah.
and a lucid.
Govind, there are some questions here. There are a couple of questions asking about in Indian patients, because our diets are different, should we have a different kind of criteria to define it as constipation, or do we just use the Western criteria?
It's not really Western category. This now, you know that the study has just come from, which is a multi-center study with the Udekosal also part of that. So probably that criteria will apply to us. I'm not sure that we will need to change our definition because of our dietary pattern. Certainly we take more fibers, so therefore we should have more frequency rather than less frequency. So defining diarrhea will be still different, but constipation I think should be. And also we know that the criteria of constipation is not only the number of stool, there are other parameters. There are 6 parameters on which you decide constipation. For example, straining, the feeling of obstruction, menu evacuation. So if any 2 of them are there, you will define constipation.
So it's not just the 3 spontaneous bowel movements per week. There are more criteria that we need to apply.
Absolutely, sir.
Right? Yeah. The other thing is that you said straining. Now, someone wants to know from Patna, Dr. Ravikant wants to know, straining, is it just a subjective criterion, or do you have some kind of definition as to how long he sits in the toilet or whatever?
I'm not too sure about it, but straining is a subjective criteria. It's not objective. Patient tells that I have to strain, and this is no. Somebody has to stay in washroom for half an hour. It might mean does this patient have a pelvic floor dyssynergia or even a slow transit. Because why the person has to stay? If there's an urge to pass stool, if it's going to washroom to pass stool, and has to wait for so long, it means there's some defect in the pathophysiology. The defect is the rectum is empty, therefore, but he going to washroom as a normal, but there's nothing can come out because there's no stool in the rectum, or there's a persistent lot of stool, but it can't evacuate because of a defect in rectal coordination.
Another question is, should we consider dyssynergic defecation as functional, or can it be organic as well? This question is from Dr. Siddesh from Bangalore.
Dr. Siddesh, this could be both organic and functional. Simply, somebody had an anal fissure. So this person will not want to go to pass stool because of a lot of pain. Passage of stool leads to pain. So those who have anorectal organic disease, especially either there is an anal carcinoma or if there is a active fissure, then they will behave like pelvic floor dyssynergia. But otherwise, most of them are functional.
2 questions on clinical thing is, one of them wants to know, where is the Neeraj from Hyderabad wants to know where is the site of pain in patients of constipation. And another question from Dr. Ajay from Rishikesh. He says there's a lot of family history that we find in these patients. Do you think there may be genetic factors, or is it just dietary factors?
Okay, 2 very important questions. And the first one, that pain, where the pain is. So if there's an organic disease, if there is some kind of obstruction, then most people will have pain in the central abdomen. That point was organic. But other one is like feeling of heaviness, or feeling of because the rectum is full, and therefore person will have that feeling of pain or discomfort is more in the lower abdomen because there lies the rectum or in the pelvis. So they will have a heaviness in the perineum or lower abdomen if there is a obstructive type of defecation, but otherwise it could be central. And we know the IBS patient's pain will have both mid abdomen and lower abdomen. The coming to second part was what is the question? Just one point.
Family history.
Family history.
Family history.
All this behavior of bowel movement and constipation is familiar. And this is one of the important determinants of constipation in our society. We know that most Indian will believe that all disease starts in abdomen. And they would see that any element they have, everything is my pate is a region for everything. If a person sees his father goes to washroom twice a day, morning and evening, the son learns from his childhood, or daughter learns from childhood, that have to pass stool twice every day, and that becomes a habit. So family may not be genetic in nature, genetic for some disorders, but more of a learned behavior since early part of life, that they they relate the same with. So those family have a constipation as a symptom, many in the family will say the constipation as a symptom for any abdominal unwellness, they come with symptom of constipation.
Okay, one last question before you move to the next phase. We'll take up the other questions later. This is a question from says, what are the causes of normal transit constipation? Why do they get constipated?
So again, this is really not known. So look at a typical example is IBS or functional constipation. Functional ones we don't find. The 2 point I want to make here, and there's a lot of confusion about it. Functional constipation and IBS. IBS, 3 types: IBS constipation, IBS diarrhea, IBS mixed or undifferentiated. So those who have a pain, we call it IBS. Those who don't have pain, we call it functional constipation in the ambit of functional bowel disease. Therefore, but there are studies available in those functional constipation and IBS that in some the chronic motility is low, in some it's even fast, but it's not really not known. More important is a perception, and one of the basic pathophysiology of IBS or functional constipation is a perception. The rectum is slightly less sensitive, therefore it does not induce the defecation reflex, and therefore patient feels constipation.
I think we'll move on to the next part of your talk and take up, there are plenty of questions. We'll come back to them subsequently. Thank you, Govind. Just go ahead.
Thank you so much. And we can move to our 5th strategy, that is treat and optimize. And before we treat to optimize, we left at who needs investigation. So what are the investigation? We filtered patients who require investigation. We know those who have organic disease, those who have a pelvic dyssynergia, those who have a serotransit will require some investigation. So what investigation? So mapping the disease, we need to know that if there are alarm features, if there is rapid worsening, if there is new onset symptom, especially in elderly, and if there are obstructive defecation, then it means this is an inflammatory or mitotic disease, and surely this patient will require a endoscopic examination, either sigmoidoscopy or colonoscopy, or CT angiography, depending upon what your clinical differential diagnosis here. So these patients will certainly require investigation depending upon what other clinical features are there. So those patients who have no urge to pass stool, they have constipation for a long time, they pass stool every 6th, 7th day or 5th day, and rest they don't pass stool, they require high dose of laxatives, and they come after years of consultation at many places. Most likely they will have a slow transit constipation, and this could be because of diabetes, hypothyroidism induced myopathy, or many other such conditions, and therefore we need to survey systemic diseases. For slow transit, we talk about colonic transit studies, and this patient will also require colonoscopy to rule out any obstruction, and ultimately, if there are facilities, we want to really map that what is the defect in colonic motility. For those who have persistent urge to pass stool, you think of pelvic floor dyssynergia. We need to do 2 things to know. We want to know pelvic floor function and pelvic floor structure. For look at function, we want to do high resolution anorectal manometry. We want to look at rectal sensation, and look at structure. We want to do defecography, which could be either barium or MRI based defecography. And those who have IBS or functional constipation, they may not require any specific investigation. At best, depending upon, we might do a sigmoidoscopy, but otherwise, certainly hemoglobin and ESR to be done to look at if they are underlying. And I must point here again that all these diseases, they all pass through a spectrum, and all these will qualify for diagnosis for IBS. So one, keep in mind that which IBS will require investigation is our clinical sense. So coming first to a transit study, again I tell you the principle of transit study. If you give radiopaque markers to these patients, if there is a pelvic dyssynergia, you find all the markers are here in the rectum, and they will pass. This is called pelvic dyssynergia. If they're spread all over, this is slow transit constipation, and normal should not have this. So this is the 5-day protocol, and the Gonzalez published that Indians have a faster transit, so you can do X-ray at 60 hours. So this tells us that what this patient could have, and this can also be assessed by nuclear scans also. Second point, how do we assess pelvic floor? Again, as said, that what we want to know about anal sphincter, their normal tone, how they relax during process of defecation. We want to look at symmetry of sphincter. We want to look at a coordination between sphincter and rectum by if rectum contracts, the external anal sphincter should relax or internal sphincter should relax. And this is a recto-anal inhibitory reflex, which we see in either manometry or even in distal rectal examination. Even in distal rectal examination, we can look at recto-anal inhibitory reflex. And if this is absent, then we know this is a Hirschsprung's disease. We also look at rectal sensation by inflating the balloon in the rectum and look at what volume the patient has sensation of feeling of the balloon which are inflating and when he had pain. So these points tells us about these all can be found by doing a anorectal manometry. And to look at the structure, we want to look at what happens with the anorectal angle during defecation, how much the pelvic floor should descend. Normally it should descend by 3 centimeters. So this we get to know by barium or MR diffography. And all this could be screened. So the pelvic floor, if you suspect pelvic floor dyssynergia, this could be screened by doing a test called balloon expulsion test. And balloon expulsion test, it means you put a catheter in the rectum and ask the person to bear down. If person bears down this inflated balloon from rectum within 1 minute, this is a normal. This person, you can say that this person does not have pelvic floor dyssynergia. And this can be done even at places where there's no manometry facility available. Taking a tube, rise tube, putting in balloon, and then that you can do that. Now, in manometry, there are some characteristics of pelvic floor dyssynergia. And so you would like to do manometry in those patients who have a clinical diagnosis of pelvic floor dyssynergia. It means they have straining, they have menu evacuation, they have a feeling of incomplete evacuation and persistent urge. If they are there, you will think this patient have a pelvic floor dyssynergia, and therefore you might refer this patient for manometry. And in anorectal manometry, we have 4 types. And I just to point again that for during normal, if there is increased rectal distension because of a good amount of stool, and person bears down, the anal sphincters will relax, right? So rectal contraction, anal sphincter relaxation, the 2 main factors. This is a push force from above, the rectum contracts and anal sphincter relax, and that leads to defecation. What happens if you find the rectum is contracting, because we see a red zone here, red means high pressure. The person is contracting, he is passing stool, trying to pass stool, but the anal sphincter, rather than becoming low, this would be yellow or blue, this is a high. Red represents high pressure. So while the person is attempting defecation, the anal sphincters are not opening up. The pressure rises. That's called paradoxical contraction of anal sphincter. This is a pelvic floor dyssynergia type 1. And this is one of the most common type of pelvic floor dyssynergia. And there are other 3 types also, but this is the most important type. It means the push force is there, but anal sphincter does not relax. And we want to know the whole process of defecation. We do a defecography, which could be MR. MR is much better than barium defecography. And now MR defecography is available at many places. And there you look at anorectal angle, the opening of anorectal angle. You look at descent of the pelvic floor, and based on that you will decide there is any amount of abnormality. And you can also look at prolapse of rectum in this defecography. So this is again important investigation. Every lesion have a spectrum. No lesion have a full-blown disease at one time. They pass through multiple phases, and they can present at any point of time. So as a clinician, we must remember the spectrum of manifestation. If you remember the most classical manifestation, there will be end-stage disease. And they're easy to make a diagnosis because the symptoms are very classical, but the opportunity to treat are much less here. In advanced disease, we just do palliation. So one need to, as a clinician, we need to understand the whole spectrum of manifestation. For example, again, look at this person who has a small polyp converted into malignancy, and over time, the tumor increases in size. Early lesion may just look like a functional constipation, but with time, this tumor become more symptomatic. He may come at this stage when there is a small lesion. He may come at advanced stage when you're sure that there is a large obstructive lesion, because symptoms are quite remarkable here. More constipation, bleeding per rectum, feeling of there's a clinical obstruction. We are happy to make a diagnosis here, but this is an advanced stage of disease. We'll be more happy to diagnose this disease at this stage where I have more opportunity to treat this person. And one also remember that those patients who have a defective myopathy or neuropathy disorders of smooth muscle, before they become classical chronic obstruction or pseudo obstruction, they always have phase when they have a slow transit type constipation, or they can present just like IBS. And now we have Indian guidelines on constipation, which is led by Dr. Uday Ghoshal, and this is published last year in our journal. So one would like to read this article. Now, so with this, we mapped the disease, we mapped clinically, and we did an appropriate investigation. Now coming to how do you treat and optimize therapy. So as usual, the first one is educate and reassure them, increase bulk, and utilize gastrochronic reflex. Just to repeat again, that ask the patient to attempt bowel movement for 5 minutes, twice a day after major meals, at 30 minutes after eating, even there's no urge. And modify the modifiable patient factors, which is again important. There's some drug is causing constipation, maybe try to change the drug to other class, likewise. So principal constipation are 3 principles mainly, that you need to have patent tract, which is mainly organic. So the tract should be patent. There should be a good amount of bulk of stool. Small bulk will have difficult to pass stool, and they should have good amount of water content. Dry stool is difficult to pass and difficult to move. So there should be a good amount of water content in the stool. There should be adequate intestinal motility, and there should be appropriate defecatory apparatus. And all these pathophysiological abnormalities which we detected, which we discussed earlier, will decide what treatment patients should receive. Coming first to appropriate stool bulk and water content, which is the prime of therapy, which is the first line treatment of constipation or laxatives. And here we have first line drugs and we have second line drugs. The first line, the bulking agents, the hyposmolar agents, the colonic stimulants, the stool softeners so that the stool can pass easily, lubricants, and enemas. So these are the first line therapy. I think all of us know about it. And we have second line, which are newer drugs. There's where we can put more water into the colon and increase motility in the colon. We'll come back to each one of them in quick succession. Coming to the bulking agent, so more fibers to the diet and to the we can add as a supplement. But please remember one point, that Indians already have a good amount of dietary fibers. They already have about 40-50 grams of fiber per day against recommendation of 30 to 40 grams of fiber. Against the recommendation of 30 to 40 grams of fibers, people are only taking more fiber. So giving more fiber may do more worse to symptoms, because these fibers can lead to bloating, flatulence, and other defects. So fiber is not therapy for all constipation. One need to know that if the personal fiber intake is low, you add fibers. Then we have a hyposmolar agents. One of them is a polyethylene glycol, which are come at 17 grams sachet, and this is a good drug because this will increase the water content of stool, and therefore the easy to pass stool. One can use lactose also, but lactose also has a side effect of sweet taste. Stimulants are not very commonly used. Those who have a slow transit type constipation, one can use bisacodyl or one can use sodium glucosulfate. And I believe these two are wonderful drugs for treating slow transit constipation. And many people use Senna. Senna is mainly once you must be seeing that a lot of patients take Kayam churn, which also has a Senna in it. Then one can use lubricants like we can use paraffin, you can use magnesium, and one of the example is where you can use any kind of preparation which has a paraffin, liquid paraffin, which helps in propulsion of the stool, and certainly enemas. So So we need to increase the stool bulk and water content. But other thing, a new thing which has come up over the last couple of years or a couple of, I would say 1 decade, is the measures where you increase water in the colon by 2 methods. Either you inhibit water absorption in the colon or add more water to the colon by some drugs. We know that a lot of people believe that I take 2 liters of water per day before I go to, or say I take 2 glasses of water after getting in the morning and I go to washroom. But this water taking with meal or without meal or even at morning time will leads to increased gastrocolonic reflex. Therefore, you are inducing the bowel movement by inducing gastrocolonic reflex. But this water will be absorbed in the jejunum or ileum. So this water will never reach colon, which is our purpose. We want more water in the colon. But taking more water intake through mouth will not increase water in the colon because this will be absorbed. Therefore, you use polyethylene glycol, which is not absorbed, which because of osmotic effect, it goes in the colon. But how do we do that? Still, how do we do that? So there are ways to do that. So for that, we need to know the receptors and which are there on introcyte. So this is introcyte. On introcyte, we have multiple receptors. We are aware there's the CFTR receptor, there's the chloride channels, and these 2 receptors will release chloride into the lumen from the introcyte. So therefore, once chloride comes out, the sodium comes out, the water comes out. So these are called calcium channel activators. So this is one of the methods which have been used to make new drugs for putting more water in the colon. One can also increase motility of intestine by using prokinetics. So what are these drugs? Let's come to these drugs. So we have a chloride channel activator. Chloride channel activator is a lubiprostone. We have other drugs. For example, they increase cyclic GMP in the introcyte. These drugs are linaclotide and plicanatide, and these drugs lead to cyclic EMP and leads to more chloride secretion in the lumen and therefore more water secretion in the lumen. So what are the chloride channel activators? We have 2 drugs, lubiprostone, which increases the stool, puts more water into the colon, and therefore it improves the GI tract motility. And this drug has been found to be effective in terms of decreasing severity of constipation, improving stool consistency, improving pain, improving straining, and improving abdominal distension. And this is now one of the important drugs for constipation. The dose for this in functional 24 microgram twice a day, and in IBS is 8 microgram twice a day. Certainly, this drug must not be used if you suspect mechanical GI obstruction and should not be used in pregnancy. The other drug is, this drug is available in our country. I think many of you must be using it. The other drug is linaclotide, which increases cyclic GMP and therefore leads to activation of CFTR and chloride channels. Therefore, put more water in the colon. Again, this drug also is found to be efficacious compared to placebo. The other drug which is not available in our country, this is a plicanatide. 2 RCTs, better than placebo, but again, look at response is just 20%. So certainly it will have a high number to treat if you use this drug. Other new drug which is coming up, this is called sodium hydrogen exchange inhibitor. This is tenapanor, and this is looks to be a good drug. This is not available, is not approved till now, but one study in IBS constipation type in 356 patients, 2 studies in fact, and shows that it improves constipation in 61% of patients. So this is likely to be an important drug in the portfolio of constipation. Third principle of treatment, improve intestinal motility. So we know that if you have a 5, so histamine is important component, 5-HT is important component which improves motility. And there are multiple types of histamines that's called multiple type 3 and 4. So this 5-HT4 agonist, there are many drugs, that's cisapride, tegopride, which are now banned. The new drugs are prucalopride and neronapride. So these drugs are becoming an important drugs in the portfolio of constipation. Prochloropride available as 1 milligram, 2 milligram, or 4 milligram. In our country, is available as 1 milligram and 2 milligram. That is agonist of 5-HT4 receptors, and therefore it improves colonic motility. And summary of 6 phase 2 and phase 3 studies using prochloropride. If you look at more than 3 stools, it varies from 12 to 56%. And now the one phase 4 studies over 6 months shows 21% patient have a improvement in their symptoms. Other drug that we know, the bile salts, if it's not absorbed, then leads to diarrhea. So if you block the bile salt transporter in the large intestine, that can lead to more water in the, so more bile salt in the stool, therefore more water in the colon. Therefore, this method have been used, and this is a bile acid transport inhibitor. The drug is ilobixet, and this drug is efficacious in 22% compared to 10% in placebo. This drug is still not available. So which drug, so many drugs, which drug to choose? We have 2 ways to look at it. Either we have a data based upon head-to-head comparison or network meta-analysis. I'll come back to that. So looking at what is the number needed to treat, which are the good drugs? So this is a pool of many studies that if you're using osmotic agent or stimulant, the NNT is just you have to treat, to get benefit, you treat 3 patients. Polyethylene glycol, much better. You treat about 2.5 patients, 1 patient you get better. Levoprostone, NNT is 4, and prochloropride, NNT is 6. So still now, in garden variety constipation, our usual laxatives, they are better. And these drugs are to be used because they have to use more patient to get benefit. So these drugs are to be used in special situations. And I'll come back to that in an algorithm. And now we have a data that network meta-analysis. It means all the drugs have been tested. They're not comparison directly, but they're indirect comparison using network meta-analysis. And here we find that the drug diphenylmethane laxative, basically these are bisacodyl and sodium picosulfate, they are found to be the best drug at 4 weeks. At 4 weeks, data suggests that if you use either bisacodyl or sodium picosulfate, they are the top effect. They are the drug with top effect. Only 50% patients have a failure to respond, means 45% improved their symptoms. And we have for example, if you use as other drugs, like for example, linaclotide is only 10% benefit. So 90% chance of failure. With this, chance of failure is only 45%. So at 4 weeks, these are the best drugs. And at 12 weeks, if you look at 12 weeks data, then we have a prochloropride at 2 milligram dose is supposed to be at top of all the anti-constipating drugs. But yet, we don't have the best drug available, and we will have to use multiple strategies which put more water in the colon, and they also have a prokinetic effect. Either in one drug or 2 drug combination should be strategy, that you are targeting multiple sites for colonic movement, and also use a combination to have a synergistic effect. And coming to last part, that is appropriate for those who have a pelvic dyssynergia. We have a treatment called biofeedback. And biofeedback, where you teach the defect by showing what's happening on a computer screen. That one patient defecates, you'll see what is the what you demonstrate them. There's a paradoxal contraction. You teach them how not to do that. And there are 3 principles of that. If there's a paradoxal contraction, do biofeedback. If there is a impaired rectal sensation, then you train by increasing put the balloon in the rectum and keep increasing the volume so that the rectum become more sensitive. So by doing biofeedback, we can treat patient with pelvic floor dyssynergia. So summary of this, for treatment and optimize, we have first line drugs, we have second line drugs, but more important, sometimes you have to use combination, if especially those who are refractory, and keep rotating because constipation may be for multiple years, to keep rotating laxatives in the treatment. And coming to last part, that is special situation. And one of the important situations is laxative overuse. Opioid overuse, and this opioid can lead to constipation. So in this, those who have opioid-induced constipation, standard drugs can be used, and they are effective in 40 to 60%. But those patients who don't have respond to this, then the other class of drug called PEMORAs, that is a peripherally acting mu opioid receptor antagonist, basically antagonist to opioid receptors, and the drugs which is Relistor or methyl-naltrexone. So this can be used for opioid-induced constipation. Recap, we define slow transit constipation. If there's no patency, they don't require any test, diagnose IBS or functional constipation using Rome criteria. Thinking of slow transit, no urge to pass stool, stools at every 4-5 days. Early, it could be advanced disease, and here we like to use transit study or nuclear scan. Pelvic floor dyssynergia, those who have persistent straining, persistent urge to pass stool, pelvic, the perineal discomfort, signifying pelvic floor dyssynergia. Screening by balloon expulsion test, manometry, rectal sensation, or difficography. If combination, 30-40% will overlap, then you will have to combine these investigations. So last part, summary, how do you treat? If you have a functional constipation, use fibers, polyethylene glycol, or liquid paraffin. If they don't respond, you might use bisacodyl or sodium picosulfate. You can use pyrochloride. You can use this drug. If there is a slow transit constipation, ask them to take a lot of water to induce a gastrochronic reflex, and ask them to try bowel movement after meals. First line treatment for those who have slow transit constipation, bisacodyl or sodium picosulfate or prucalopride. And try combination. If they don't respond to one, try combination. If they don't respond, you might try pyridostigmine. And this drug is not really approved. This we use as a part of patient care, and we have used this drug for those who have refractory constipation, especially slow transit type, and we found this drug having efficacy. And those who have most advanced slow transit going to colonic fluid obstruction, then one can do surgery. But this is only a rare event. Those who have pelvic floor dyssynergia, what not to do? If you have pelvic floor dyssynergia, one thing one must not do is don't give fibers. Fiber is not panacea for all constipation. If you give fiber to this patient, you saw a picture, the stool will become more in the rectum and there will be more discomfort, more symptom. So if you suspect pelvic floor dyssynergia, don't give fiber as a treatment for this person. Treatment is biofeedback, which may not be available everywhere, but if it's available, this is very effective in up to 60 to 70% patients. Now this biofeedback can also be done at home, which is not available in our country, but in the US, people are using, especially Dr. Rao, who is the master of constipation, he's a world leader in constipation. They have devised a home-based biofeedback, Dr. Satish Rao, and we need to teach them diaphragm exercise. I could show these things by showing, but again, this is not platform where I can show, and they are relaxation technique. If not available, refer for those centers for biofeedback. But meanwhile, you try something which is a polyethylene glycol or liquid paraffin or combination and modify the dose. So those who have a refractory constipation, the reason is simple. We are using inappropriate doses. We are using inappropriate patients. And more importantly, we are using a inappropriate therapy in this patient. If I use fiber for slow transit, the symptoms get worsened rather than getting better. And therefore, we must focus on pathophysiology, assess the cause, provide psychological assessment to these patients, and try and use combination. Modify all the modifiable factors, and still we know that no treatment of constipation provides 100% benefit, and therefore we need to have better drugs in this therapy. Lastly, the constipation is a big problem for any society. The person who suffers from constipation, they have very poor quality of life. They have millions of visits to doctors, and they undergo lot of investigation. If you look at the global population of, say, 10% prevalence of constipation, we have 700 million people in the world have constipation. And India itself, we have 13 crore people will have constipation. And if you look at perceived constipation, where patients feel I'm constipated, almost in our own country, there will be 21 million. Overall, 21 million people will have a perceived constipation. So we have a lot of unmet need. We need to change behavior of people. Indian people we should tell, as a physician, we should tell what is perceived, so don't worry about it, and what is true, which requires specific therapy. We need to have better understanding of disease. We should have simplified description of disease. There is a lot of confusion in literature. Everybody has a different classification of constipation. Therefore, the reader gets confused. Therefore, we should have a simplified description of the disease and drug with better efficacy. So in summary, what I told you, that first thing, decide is a perceived constipation or a true constipation. True constipation, we need to go to next steps. In perceived constipation, counsel and utilize gastrocolonic reflex. Classic constipation, if it's a true constipation, classify into functional or organic. If it's functional, we divide into normal transit, slow transit, and pelvic floor dyssynergia. And I told you, slow transit will have no urge to pass stool. Pelvic floor dyssynergia will have a persistent urge to pass stool, and this is how we decide. We go to patient factors, look at their age, look at the setting, comorbid illness, more importantly, rapidity of this thing. And then we map the disease, either slow transit, pelvic floor, IBS, or the organic. Use urge as a clinical parameter, and please use a distal examination, which sometimes can replace manometry, and filter who requires investigations and do appropriate investigations. Every patient with constipation does not require investigation. Optimize using first-line drug. If don't, second-line drugs, or use combination or rotate. And in a special situation, we have special answers. So with this, I end my presentation and maybe ask two questions to audience as a part of interaction with the audience. Number one, if I give a clinical situation, here's a 54 years old male, have constipation for the last 15 years. He passes hard and dry stool, had feeling of incomplete evacuation, and often remove the stool digitally. Which of the following drug we will prefer to avoid? Chlorpride, polyethylene glycol, fibers, or liquid paraffin. You can mark this on your, the question must have popped up on, you can mark your answer 1, 2, 3, 4. Those who are on Facebook, they can write 1, 2, 3, 4.
We're giving 1 minute for this, and we will have some answers coming up on the screen. Dinesh?
Yes, sir.
You have answers?
You have the answer?
Amol sir, just share an answer.
Answers on your screen, sir.
You can change your screen or you can read, Amol, you can read the answer. You can unmute and read the answer.
It's 57% saying fibers and 22% PEG.
Sir, perfect. So certainly we will not like to use fibers in this subset of people because fiber will further worsen the constipation, because this history is typical classical of pelvic floor dyssynergia. Now let's go to one more question, which is have you ever made a diagnosis of pelvic floor dyssynergia in your clinic? If you say yes, put 1. If you say no, then put 2. Those on Facebook can say yes or no by typing 1 or 2 respectively. Answers, please.
Yes, sir. So 61% are saying yes, and almost 60-40. It's 60-40.
So wonderful. So with this, I stop my presentation, and my apology that I didn't realize that I crossed time by leaps and bounds. Is almost 1:10. My due apology for uh, losing my sense of time while speaking on this topic.
Okay.
I believe
I think you could see your involvement and your eagerness to teach and communicate the messages, Govind. So what we'll do now is, although we have a relatively less time left, we have about 15 minutes in which we'll try and take as many questions as possible. So I'll start off with some questions primarily dealing with the investigations and a few questions about the mechanisms. While I think the treatment related, there's a large number of those questions. Some of them I'm hoping Dr. Bhatt will take up thereafter. So coming to the investigations, Dr. Krunal Patel from Jaipur as well as Amit Joshi from Indore and a few others wish to know about the balloon expulsion test. In what position do you recommend should it be done? What and whether weights are used or should be used? Anything about the duration and other details about how do you normally perform a balloon expulsion test in your practice?
so. If you do we do normal ones. That normal means you put 50 ml balloon and ask the person in the left lateral position to evacuate this balloon. And if you evacuate within 1 minute, we can say that the coordination between rectum is good and less likely this person have pelvic dyssynergia. But sometimes you put a weight, and weight put over it is half a kg and 500 milligrams, and see that if the person is able to. If person is able to do a weighted, then you can always say that there is no pelvic dyssynergia.
Right. So, well, with from over 210 questions by now to choose, it's going to be difficult. An interesting question is from Dr. Antariksh in Chandigarh. Where do you place the breath test for Methanobrevibacter in the treatment of chronic constipation? I think that was something that is of interest.
Absolutely, yes, it's important, and Uday Ghoshal has some work on this. That we know that the methane is produced in the into the colon. Methane is a it inhibits colonic motility, and therefore, if we have a bacterial overgrowth, and especially in the colon, and if they have a Brevibacter methane, if there is a bacteria which produces more methane in the colon, that can lead to decreased motility. And there are data now that data from Uday that if you treat these patients with rifaximin, sometimes constipation gets better. Certainly, this has a different role. That methane can have a defects, can lead to defect in the contraction of smooth muscle, and therefore one can use rifaximin in this situation.
Is it a sizable proportion of the constipated population who have Methanobacter overgrowth? I mean, how commonly should you suspect and test for this organism?
I'm not sure about this because those who are doing these studies, those who have hydrogen breath test, if you do hydrogen breath test, you'll find methane peak, and certainly those patients. But again, if you don't have tests, I don't think we have a clinical parameter to say that this patient should undergo breath testing or not. Otherwise, all of them will have to undergo breath test.
Yes. So now regarding pelvic floor dyssynergia, the question is between barium difficography and MRI difficography, are there any differences? When would you prefer one over the other? And there may be places which don't have MR. Will barium be sufficient there?
Absolutely, sir. One line answer, MR is better, anytime better, because it tells you about anatomy of muscles, the pelvic floor much better, the coordination is much better seen on that MR. MR difficography is much better compared to barium. But MR difficography is difficult to do, it takes a lot of time, and many people may not have expertise to do this test. But if available, MR difficography is the answer.
Right. Okay. Thank you. Dr. Tirumala from Pondicherry, as well as Dr. Rakesh from Lucknow and Dr. Ravi Thakur from Banaras have questions regarding you talked about slow transit constipation, myopathy versus neuropathy. So how to suspect and how to diagnose, and what exactly is the place of a colonic biopsy in the workup of these people with the presumed slow transit constipation?
Important question, very important question. So as I said, that in a common garden variety of constipation, we need to filter out which are the slow transit. And for pointed towards that, slow transit because of myopathy or neuropathy, even because of diabetes, they will have huge spectrum. Diabetes of 5 years, diabetes to 25 years. There's a different spectrum, different scale of neuropathy in them, different scale of myopathy in them. And if you look at primary also, there's different scale. At younger age, much less symptom, but as they grow, symptom may get worse. So there will always be spectra. So those who don't have urge to pass stool, and for those people who say that I don't pass stool for 5 days, and even have urge to pass stool, no doubt about it, this is a slow transit to constipation, and that we should understand that how far they will progress. They might progress to the stage when there is a chronic intestinal pseudo obstruction, late stage. But all these patients will present with a slow transit type constipation. So urge to pass stool or passing stool very infrequently is the pointer to think of a slow transit constipation. Colonic biopsy in these patients probably are not very useful because whatever biopsy we take by endoscope, we just take mucosa and submucosa. We don't reach muscle layer. And therefore, doing just colonic biopsy probably will not, I mean, if you find some mucosa plexus, they are immunohistochemistry markers, but you will miss if unless you go to site of disease, that's a muscle. Unless we reach muscle, we can't differentiate. Therefore, either they're called open biopsies or this is how it is done.
So how does biopsy help the management? Is it important to differentiate myopathic versus neuropathic? If you're thinking of a total colectomy, is that the time when you want to do biopsies? What exactly is the place for biopsy in these people?
So biopsy is done mainly in those patients, especially the early part of life. If you're thinking of Hirschsprung's disease, they would do biopsy, full thickness biopsy, and then because it matters there. But those who only have advanced disease, no point doing biopsy there. Certainly, but there are only few patients. They require maybe pancolectomy. But important point that why do we allow these patients to go there? Even if we pick up them early and they treat them, probably we can decrease their suffering.
Okay. Regarding a few questions about the mechanisms, Dr. Shubhankar from Hyderabad wanted to know about chronic constipation in pregnancy. Is there a difference in the mechanism, and are any investigations needed in that situation, or how would you handle that?
So, as I said, this is a very important issue that constipation pregnancy is because of effect of estrogen. Pregnancy is a hypoestrogenic state. Therefore, there will be colonic motility may come down. And also noting that the pressure of the fetus or enlarged uterus will also have bearing on the anorectal function. So therefore, but again, we don't have to use high-fi drugs. Simple using either lactulose or even polyphenol glycol will do the trick.
Right. Dr. Achal has an interesting question. Achal is from Bangalore, and he wants to know about Proctalgia fugax. Is it organic or is it functional, and how to treat the condition, how to diagnose and treat the condition?
So Proctalgia fugax is a condition which is mostly functional in nature, and probably we thought about that we do masterclass on this. So we're thinking of doing this masterclass in the whole segment because this is an important part for all of us. That how do you treat the whole spectrum? It's not only one. This is a common term like Proctalgia fugax, but in that there are multiple subtypes, and probably will request one of our experts in neuromotility to talk on this.
Right. Regarding the sense of incomplete evacuation, which is quite commonly described in IBS of the constipation type, Dr. Jagannath from Madurai wants to know, can we explain the mechanism of what is the genesis of these symptoms of so-called feeling of incomplete evacuation?
So that's important, incomplete, because if there's a lot of stool in the rectum and is not evacuated, so patient will have it because rectal pressure is high. Rectal mucosa always perceive that particular the stool is still there despite having full bowel movement. So this is one. Number two, more important in terms of IBS is a rectal hypersensitivity. That for the small amount of stool, the patient already perceives there's a something there, and these are two types. One is functional hypersensitivity or visual hypersensitivity because of a functional disease like IBS. And for example, in IBD, because of inflammation, you have a visual hypersensitivity. Therefore, you have recurrent urge to pass stool. You go to washroom, you hardly pass some amount of mucus or some blood, but no stool. And this is all because of a visual hypersensitivity, and which is the hallmark of IBS.
Right. Last question before I pass the baton on to Dr. Naresh Bhatt for the next 5-6 minutes. Is very interesting question from Dr. Ajay Kumar in Rishikesh. In diabetic constipation is very difficult to treat. are you aware, or are there any developments on the use of electrical stimulation therapy or pacemaker implantations for any subset of people with chronic constipation?
They are certainly this, not only for diabetes but also for primary myopathy and neuropathy. There are some development again, but they are not available, and I'm not really updated on this at this point of time. I read some papers some time back, but not updated myself over last
Right.
for last
It's
4 years.
something that's happening, and we need to keep track of it. Dr. Bhatt, can you please
Yeah,
start with some questions if you
yeah.
have?
There are a couple of questions basically on perineal descent. How do you really examine for perineal descent? Do you prefer it in the squatting position? And how do you diagnose a rectocele, and what is the role of surgery in rectocele?
So,
This is from Monish from Chandigarh.
so hi Monish. So this is a rectocele is important, and especially the rectocele after childbirth in our women, if they are unsupervised supervised deliveries, there's a damage, and rectocele becomes also an important issue there. Rectocele can be diagnosed easily on either barium or MR difficography. And the criteria that we take a normal descent is about 2 centimeter descent, and you look at from the neck of femur, you look at distance. So there are criteria by which you will say there's a rectal prolapse, but all rectal prolapse do not require surgical treatment. And I want to emphasize time and again here that rectal prolapse may be a modifier, may not be sole cause. And if you do surgery in these patients prematurely, we are going to worsen their symptom rather than making them any better. So only those patients who have advanced disease, we tried enough of a treatment and their rectal prolapse is quite large, only in that small amount of prolapse probably should be left alone.
There are a couple of questions on normal transit constipation. Professor Venkatakrishnan from Coimbatore and some of his other colleagues want to know, how do you differentiate IBS-C from patients with normal transit constipation?
This is a confusion. I think all of us get confused about it. Normal transit, it means this is no slow transit. So slow transit, so of all the constipation, three pathophysiology, normal transit, slow transit, and pelvic floor dyssynergia. For pelvic floor dyssynergia, we know how to diagnose. For slow transit, no urge or low urge to pass stool, and stool less frequent than usual. Normal transit means the person has a passive stool every day, but they feel incomplete. Incomplete is a part of perception. And so there's no parameter by which we can diagnose normal transit. So slow transit, we have a parameter, but there's a lot of gap between normal transit to slow transit. And all are, so this is a clinical, so we can convert normal transit to IBS-C or constipation. Both are synonym. For our purpose, we call it either functional constipation if there's no pain. Functional constipation with pain is IBS. Then we have a slow transit constipation and pelvic floor as a separate entity. And more importantly,
the question on
pelvic floor
on transit.
Sorry, yes, sir.
Sorry, go ahead. Complete.
Pelvic floor and slow transit can occur together. So all slow transits may not be end stage like chronic intestinal obstruction, but they could be an early stage where the patient don't feel to pass stool. The stool is not coming less. At the same time, whatever stool comes, they also have defect in rectum coordination. Therefore, they have combination. And combination, we must remember that this could be same patient can have both these together. Therefore, we should choose therapy accordingly.
The question again on transit. Dr. Sunil wants to know, what is the protocol for transit study? Do we use the one that is recommended in India? Has it been validated? Or do we still use the Western one?
So I may not have the final word on this because see the standard is what is defined in the West, and most textbook will write that. At the same time, the Indians may have a faster transit, and their data, both on hydrogen test-based data, that Indians have high transit, and so therefore, Dr. Uday Ghosal, only a small subset of 8 patients, he demonstrated that, but this is just 8 to 12 patients, so it's not big data. So we cannot take this as final word, but we should keep in mind that our patient may have a
maybe different.
But again, changing protocol, I'm not too sure about it.
The next issue is it's all right to differentiate as normal transit, slow transit, but does it actually make a difference in therapy? Are the response difference in these two groups? That's a question from a couple of people who have tuned in.
Absolutely, absolutely. That if we have a slow transit constipation, we should prefer to use sympathetic mimetic drugs, drug which can improve colonic motility, like procoloparide. This could be drug I prefer to use. I might like to use bisacodyl at the cost of its side effect, because bisacodyl is a great drug, but it leads to side effect in 40% patients, or sodium picosulfate. So sodium picosulfate, bisacodyl, or procoloparide, if you're thinking slow transit constipation, because the mechanism is a colonic hypomotility or colonic inertia. You need to use a drug which can improve colonic motility, and therefore you use these drugs. So in normal transit constipation, you can use any garden variety, starting from fibers to osmotic agents to lubricants, and you can use one or in combination. And if they fail, go to second line drugs like using procoloparide, the levoprostone, or even to other drugs.
Dr. Hardik from Hyderabad and many other colleagues have asked, what's the duration of treatment for procoloparide? I mean, the studies have been done on a finite duration, but how long can you use it safely?
I think we can use for longer. Only thing that we want to remember that this is the class of drug which have shown earlier cardiac side effect, bisacopride and ticagrelor. Therefore, the drug have been banned from clinical use. Therefore, one should remember that if you're using a patient who have a pre-existing cardiac disease, you should be more careful about these drugs. But these drugs are the study which are available 6 months post-marketing surveys, but people are using for even longer period of time if the drug works well. Or one can also do that switch on to therapy in between. So you use a procoloparide for say 6 months, then switch on for some time, for maybe 2-3 months, then go back again, kind of.
Well, Dr. Naresh, I think we are now reaching close to 1:30. I think there are over 230 questions, and probably we'll be here the rest of the evening if we try to answer many more of those. So I think it now is my pleasant duty to thank Professor Govind Makharia for a superb exposition of the subject of chronic constipation, an extremely common problem, and with a lot of misperceptions and misconceptions prevalent Western, Indian controversies around. I think he's done a great job of simplifying them, going systematically and point-wise, and giving you a roadmap of how to approach these patients. So thank you very much, Govind. And also, I thank you, Dr. Naresh Bhatt. Thank you very much for a lot of thoughtful and thought-provoking questions, putting them, the ones that have come from our viewers. Well, I think this is the 12th talk in this series of ISG masterclasses, and we are now shifting gears. We are changing to a format in which we'll be having these masterclasses once a week. So the next time we meet for this will be next Sunday on the 31st of May, again from 12 noon to 1 p.m. And the topic for the discussion for the masterclass next time is going to be functional dyspepsia, which will be presented by the speaker will be Professor Usha Datta from PGI Chandigarh. So we look forward to meeting with all of you once again next Sunday. And before we leave, I think I would like to also thank our technical team. Dinesh and Amol and Ramesh have been doing a great job, and Yogita has been very competent in putting forward all these huge number of questions that 235 now that have come in from the viewers. Also, I'd like to thank Sun for their continued support to this effort for the master classes. And with that, I think we can come to the end of the session. Thank you all for participating and making these master classes such a success. Thank you. We
Thank
can now.
you. Okay, bye-bye.
Bye. Bye.